Hi, everyone. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. Thank you for joining us at Spine Talks today, where we deliver unparalleled access to world-class experts, like the doctors who are joining me today. We're in Miami at an international spine conference, where doctors and surgeons are talking about the latest techniques and technologies in spinal healthcare. We're going to be talking about tumors of the spine, cancer in the spine. And I'm going to turn the program over to Dr. Tom Schuler, our moderator today. And Dr. Schuler is the chairman of our Medical and Scientific Board. Tom?
Thank you, Rita. It's so exciting to be at this international meeting, learning from the best about how to deal with problems of the spine. And today's issue is going to deal with possible cancer of the spine, tumors of the spine. The good news is, rarely do people have cancer of the spine. I've been in practice over 30 years, and it's less than 1% of the time that somebody gets diagnosed with a tumor of the spine. Almost everybody that comes to see me has a concern in the back of their mind, if not at the front of their mind, do I have cancer? And when you have neck pain, thoracic pain, which is where the chest area is, or low back, people often are like, is this cancer? I should get it checked out. And the good news is that's rare. But in the few cases that it doesn't happen, that's what we're here to talk about today. If you get diagnosed with cancer, what do you do? And fortunately, we have experts from our Medical and Scientific Board. We have Dr. Dan Schuerba, Dr. Larry Rhines. Dan's from New York and Larry's from Texas. And they're here as our world-class experts to help us understand better what to do if you are diagnosed with a tumor of the spine. So I'll let them introduce themselves. Dan?
Dan Schuerba from Northwell, New York. Specialize in all of spine, but a large focus on spine tumors.
I'm Larry Rhines from the MD Anderson Cancer Center in Houston, Texas. Patients with spinal tumors is my practice.
So to start off, when somebody comes in and they're worked up and they get diagnosed with a tumor of the spine, we have to understand, is this something which is starting in the spine or spread to the spine? So Dan, do you want to talk a little bit about that?
Great segue. So just to echo what you said, when people have a diagnosis of or concern for a tumor, and if I were in that situation, become very anxious. So the first step is to understand that what you need to give patients is obviously some reassurance and a plan. And part of that plan is what you just alluded to, is what type of diagnosis is this? Is this something that started in another organ of the body and jumped to the spine? That's called metastatic. Or is it something that starts in the spine? Did it come from some of the linings of the spinal cord or part of the bone of the spine? And that is one major fork in the road. And then we start going down forks and we start including team members, if needed, radiation oncology, medical oncology, or we manage ourselves, or sometimes there's nothing to do at all because it's a benign problem that might not cause any problem in the future. But that...
What does benign mean?
Thank you for that. So, we use the word benign all the time in normal life. And this is a benign procedure for me. I went to the dentist. It was a benign procedure. When we think about tumors, the simplest way I put it is that benign is a tumor that stays in one area, where if it's malignant, it can grow in that area, really invade, or it can jump to another part of your body. So the difference is benign, meaning not cancerous, or malignant, meaning cancerous. So any mass can be called a tumor, but that decision between a benign and a malignant is one that the second one is that can jump from one part of the body to another or grow invasively, while the benigns usually are self-contained and don't jump anywhere.
Good. Larry, can you expand on that?
Well, I think Dan did a great job of laying out the basic groundwork, and I think one of our important jobs as surgeons focused on spine oncology is figuring out what exactly the problem is that patient has. And Dan really alluded to it well. Is it a malignant tumor or a benign tumor? If it's malignant and it's come from some other organ system, what organ system is that?
And malignant means what?
Malignant is more aggressive, a more rapidly growing tumor oftentimes, and a tumor that has the capacity to spread to other places. And that's in comparison, as Dan said, to the benign tumors, which tend to stay localized where they are, tend to grow where they are. The growth is often at a slower pace than in the malignant tumors, and they have a much lower capacity, in fact, don't have the capacity really to spread to other places. So that's an important distinction off the bat. Is this in the benign, slow-growing, stay-at-home family, or is this in the malignant, aggressive, likely to spread family? Very often we can get cues about which of those it is based on what part of the spine is being involved. And by what part, I don't mean the neck or the chest or the low back. I mean, is it of the bone? Is it sitting within the spine amongst the nerves or the spinal cord? As a diagnostician, the location of the tumor within these structures of the spine can give you clues as to what type of tumor it is. And then very often we use additional evaluation to figure out what type of tumor it is. We may do a scan of the rest of the body to see if there are any other spots that are involved, because that can give us information.
And that scan would be a CAT scan?
CAT scan, sometimes a PET scan is used, and a CAT scan is a high-resolution imaging that looks at the body. A PET scan is the patient is given radioactive dye into their radioactive sugar into their vein, and because malignant, fast-growing tumors are fast-growing, they consume a lot of sugar. The dye tends to gravitate and gives you an idea of where the tumor might be. And so this additional diagnostic workup, these additional studies may help you determine benign versus malignant. If it's malignant, you may see it in where the tumor started. And lastly, once we've done those studies, a very common procedure for us to order is a biopsy, where a radiologist may place a needle into the tumor to sample it in the primary site or in a secondary area, and another site of growth, to determine the diagnosis. At the end of the day, this is perhaps the most critical piece of information for the physician treating a patient with a spine tumor, is to know what they're treating. Having the diagnosis is critically important, because that'll tell us, A, what is the biological behavior of this tumor? What is it? B, what are the best treatments? And one of the things I think we'll get to is the fact that spine oncology, maybe more than any other discipline of treatment for spine diseases, is very multidisciplinary. And what I mean by that is it very commonly involves physicians in multiple areas of expertise. A surgeon, perhaps, a radiation oncologist, perhaps, a medical oncologist, a doctor who gives chemotherapy, or all three. And so I think determining what it is we're dealing with is maybe the single most important step when you initially meet a patient with a tumor in their spine and have to chart a course for them.
You know, it's interesting. We talk about people having a tumor of the spine, and then the biopsy, which is to get a piece of that tissue so we know what it is. But often, if it's spread from another place or has spread to another place, they may biopsy it where it's easiest to get at, and that may not be in the spine. So if there's a lump that is noted in something that's easier to get to, such as in the skin or in a area of a different bone, that may be the source of the biopsy. So it isn't always in the spine. I'm going to switch gears a little bit. We've talked about tumors of the spine, but we have to understand that there's the nerve tissues of the spine and the bone tissues of the spine, and they're both critical. So we're going to start now and have a brief conversation about tumors within the nerves of the spine, or in the sac or the dura, which holds the spine, and the peripheral nerves versus the actual central spinal cord. So do you want to just touch base a little bit about what kind of tumors we're talking about and what the treatment for that is, as opposed to the bony? We'll get to the bony later.
Absolutely. So, when you think about the spine, and sometimes people say my back or my neck, and other people say my spine, and we sometimes as surgeons have to be educating patients that when we say spine, that does mean the neck or the back. But even with that, it is in the center of the body, and there's a lot of things that basically, like a train station, run in and out of that area. You mentioned the bone, you think of the skeleton, and we can get to that, but it is the center of our skeleton. You think about a picture of a skeleton in a picture, that spine goes all the way from the head down to the pelvis. But within that, all the nooks and crannies is the spinal cord that comes from our brain and is the major thoroughfare of signals that goes to our arms and legs and our ability for some of our internal organs to work. And then there's nerves coming off like branches off a tree. So the spinal cord is the trunk of the tree and the nerves coming off our branches. And every aspect, whether it's the bone, the nerve, the spinal cord, the covering of those, there's actually coverings of those that can cause tumors, that each one of those, as Larry alluded to, is a different origin of a different cell type, and each one has a different story. So sometimes patients will say, literally, maybe a family friend will say, there's a ball or a mass or a tumor near my spine, and I still have a huge thought process of what it could be. It's still a very encyclopedic. Is it from the bone? Is it from the nerve? Is it from the spinal cord? And so as Larry alluded to, imaging is the first aspect, imaging meaning X-rays, MRI, CT scans, to say, oh, that's coming off of the nerve. That narrows our thoughts on this. It's coming from the spinal cord. That narrows it. Very, very few things come from the spinal cord. If it's in the bone, well, maybe we start thinking about other tumors that grew to the bone, as we alluded to before. But that is the first thing, and that allows me sometimes to say to patients, it's no longer encyclopedic. The images have narrowed this focus to a certain thing. The next step, as we talked about, is scanning the whole body, which may give us further clues. And if we're still not sure, or to make it absolutely 100% sure, is where you get a piece of that tissue, where patients will say, what is this? And you can never say for sure until you take that piece. But to your point, there are a number of tumors that are very technical, Schwannomas, Neurofibromas, Ependymomas. These are things that come from, the Schwannomas come from a Schwann cell. The Ependymomas come from ependymal cells. So we have all these different cells, and if we can think about where it's coming from, that can narrow it.
And those cells are in the nerves.
In the nerves or in the spinal cord, exactly right.
Right.
And so that actually allows us to narrow that. And sometimes without a biopsy, we can start counseling patients into, this is probably what this is going to be. And then as Larry alluded to, I always consider our job as not only sometimes the definitive treater as surgeons, but if this is not surgical, to be a navigator for the patient. If I were to be diagnosed with a tumor today, as a doctor, I might call some friends, but as my wife or my family members who aren't physicians, they might call 100 of their family members. What should I do? Should I see a surgeon? Should I see a doctor who gives chemotherapy? Should I see a radiation oncologist? If I were in that situation, I'd be overwhelmed. And the key is that you want someone to give you a plan and be a gatekeeper. So if they say, we can take care of it in this shop, if not, as a member of a multidisciplinary team, this is not my role. This is the role of someone who treats this with a pill. This is someone who treats this with an injection or some other medicine. And some tumors melt away with medicine, and some of them melt away with radiation, and some of them are only surgical, and some of them are all three. So that first thing, when that patient has that terrible feeling of, wait, there's something in my body, and it might be causing pain, it might be causing weakness, it might be causing problems with walking, that in and of itself is enough to make the patient anxious because they're suffering. But now they have a second level of just beyond the pain of the tumor or of the spine issue like we see with degenerative issues. Now they have this concern, is this going to be a threat to my life? The first thing is to be able to get into that navigation so that one of us, whether it's the radiation oncologist, the surgeon, or the medical oncologist, directs it to the friends and says, this is a group deal, this is your issue, and help that patient have some peace of mind right off the bat. And I think this is why this venue is so important, is to educate people out there who are listening to say, once you get into the system, the job of us is to really push you to the right person. And maybe that changes. Maybe you go and you spend time with a medical doctor, you come back and you see the surgeon later. But the key thing for the people out there listening is to get into that workflow so that we can give you a plan and give you some peace of mind.
Yeah, I think that's great. I mean, the worst thing you can do is to delay getting a diagnosis, because if it is something that's growing, it will grow more. So when you have that neck pain, when you have that back pain, and it keeps persisting for more than a month, you should get checked out and understand what's going on. Fortunately, rarely will it be cancer, but you don't know, and it's following it sequentially that helps it. Plus, also, why live in pain if you don't have to? Unfortunately, most people get better non-operatively with most pain, and it's rarely cancer, but you want to be certain about that. Larry, let's talk a little bit about the nerve tissue, the nerve tumors, and can we define a little bit about intradural versus extradural? We got to define what dura is. With intradural, extradural, could you expand on that?
Yeah, sure. So as Dan said, the spine runs through the center of the body, and obviously the bone provides important structural roles. We're going to talk about that later. But within that spine, if you look at each individual vertebra stacked on top of one another, there's a hole down the middle. And it's that hole that carries the spinal cord running from the brain to the rest of the body. And as Dan said, at each level, there are nerves that come off of the spinal cord. The spinal cord is the main trunk line of the communication system. And then the little smaller communication cables, like a phone system running through your neighborhood. There's a line that goes to each house. The spinal cord is that main trunk line, and the nerves carry information to each of the houses. In this case, it's each of the parts of the body. In the cervical spine, the neck, those nerves carry information mainly to the arms, sensation and motor activity to the upper extremities. In the thoracic spine, those nerves carry information to and from the rib cage and the muscles between the ribs. And in the lumbar spine, the low back, those nerves carry information to the function of the lower extremities, and as we go down, even to the function of the bowel and bladder. And as Dan said, those nerves are composed of cells, and those cells, virtually every cell in the body, can be the source of a tumor. In fact, very often the name of the tumor is associated with the type of cell that tumor comes from. So in the nerves, there are cells that insulate the nerves, much getting back to my telephone line analogy. There's a plastic jacket over the copper wire. That plastic jacket is insulation. And in the nerves, these Schwann cells make fatty tissue that insulates the nerves so they can transmit their impulses more rapidly. And when a Schwann cell becomes tumorous, which means abnormal growth at an abnormal rate, growth that's not restricted, growth that expands beyond the confines of what would be normal, you get a tumor. And we already talked a little bit about some tumors are benign, some tumors are malignant. When a Schwann cell becomes a tumor, you get a Schwannoma. These are benign tumors of the nerves and are typically treated with a surgery. Within the spinal cord, there are other tumors that are more common, and there are tumors called astrocytomas, which are tumors of the support cells around the nerves. And then another common tumor you might see within the spinal cord is something called an ependymoma. And that, as you might expect, comes from ependable cells. And these are cells that line a fluid channel within the spinal cord that carries spinal fluid. And so each different cell type can give rise to its respective tumor. Ependymomas tend to are benign and are also treated primarily with surgery. The astrocytomas, depending on what type, may be benign, but also some of them can have a more malignant behavior. And depending on which of those it is, you may decide to treat with surgery or radiation, chemotherapy, or some combination of those things. So it's very interesting, no matter where you are in the body, we're focused on the spine and the nervous system, but no matter where you are, the cell types, the cells that make up that structure, when they become tumorous, when their growth is abnormal, you can get a tumor, and that tumor is often named for the cell of origin in that anatomic structure.
A common term is meningioma. Can you talk to me about meningioma?
Yeah, sure. So that was a discussion focused on the tumors of the nerves. And I should add, there's one other tumor type of the nerve that we can see, and that's called a neurofibroma. It's also a benign tumor related to the nerves. That nervous system within that tube, that hole within the vertebra, has a lining around it, a covering. That covering contains the spinal fluid in which these neurologic structures sit. And that covering also is made of cells, and those cells can become tumorous and give rise to a tumor. The coverings of the spine are called the meninges, and so wait for it. I'm going with this. A tumor arising from the meninges is called a meningioma. And it's interesting, on an imaging study, when there's a big tumor there, it can be hard to distinguish on the scans whether this tumor is of the meninges and squeezing the spinal cord or the nerves, or whether the tumor is of the nerves pushing on the meninges. So sometimes you don't know with 100% certainty, but a meningioma of the covering of the nerves, the meninges, is another benign tumor type that can grow in that location and is also a predominantly surgically treated disease.
So, we talk about the term benign, meaning it's not bad, and it typically won't spread. And yet, we're talking about surgical. We have to understand we're talking to a tumor surgeon, so they're going to be seeing the surgical ones. But not all tumors need surgery. Not all benign tumors need surgery. So, Dan, can you just talk about why would we not operate on a Schwannoma or a meningioma?
Great question, Tom. And one way I like to think about things for the patients, and this is my way that I take patients through it, it's the way I take my students and my fellows and my residents through it, is about three things we should think about when we start to see a mass in the spine. This will help answer that question. One is, what is it? We've talked about that as a benign or malignant, and that's often, as you allude to, what patients want to know. I heard there's something in my body. Is this going to threaten my life? Is it going to threaten a lot of my bodily functions? But if you sit there and you say to somebody, hey, listen, we think this is benign, and they sit back and say, oh, so I don't have to worry about it. Not necessarily, because it could be a benign tumor, but it's pushing on something that's very important. So the example that I always give to patients who might not understand the spine as well, I say, if I have a mass behind my eye and someone says, Dan, I heard that it's benign, good for you. And I said, but I'm going blind. It's no longer benign to my life. It's a different use of the word benign. It's still affecting my function. So the first is, what is it? Benign or malignant, what type of tumor? The second is, what is it doing to my neurologic function? Is this affecting my ability of my arm to work? Because, as Larry said, the wires are being slushed that go to my arm. Is it affecting my ability to walk? Is it affecting my ability to have other bodily functions, bladder and bowel? And the third issue is the structural issue. Because, as we said, there's a structure holding it's our backbone, right? It's our backbone holding our spine together. And what I say to patients is any one of those three, or a combination of them, sometimes all of them, can be affected. And depending on what you have of those three, is your plan. So let's give an example now, and we'll get to your point about, do you have to do something? So let's say this is a malignant tumor, probably has to be treated relatively quickly with potentially surgery and other issues like chemotherapy or radiation. That might drive the boat. What if it's benign? Nothing to do, but maybe it's benign, it's pushing on something. Then surgery may be indicated. Maybe it's benign and it's not pushing anything, but it's eroding some of the bone in my back, causing me to have a crack in one of the bones, and I'm in a lot of pain. So although it's benign and not pushing on the nerves, it will cause an issue. Now, what if it's none of the above? What if it's benign, very, very tiny, not pushing on anything, not causing me any pain? So well, how'd you find out about it? Well, maybe I slipped on some ice, I hurt my back, and they looked at to see if I broke my back or if I hurt my back, and they, in the process of that workup, a spine surgeon or a primary doctor said, we saw something. And maybe it's the size of a grain of rice. Maybe it's the size of a grain of sand. And you sit there and say, that's not supposed to be there. It's not pushing anything. It doesn't look that malignant. And it's not causing any pain. And the patient says, well, there's something. What should I do about it? One of the things we often do is we look for clues that will tell us what this is going to do. So we sometimes say, let's watch this. And that's sometimes very unsettling to people. Why am I watching this? And the reason we watch it is because if we watch it for a little bit and it stays the size of a grain of sand or stays the size of a grain of rice, we can maybe kind of forecast that this may not be an issue forever. And so maybe it'll be an issue in 80 years, and maybe the patient is already 50 years old, and you say, I don't know if we have to worry this, but we're going what I call is a MRI scrapbook. And so, you look at the scrapbook, at least I'm old enough to say, hey, there I was in Little League, there I was in high school, and you said there, that was the MRI from 20 years ago. It looks just like this one, unlike the scrapbook where I get older and lose my hair. This says it looks the same. And so every time we say to the patient, do you want to have a surgery to have this out? They say, it's not causing any problems and it hasn't grown. So the two things what we watch for is a picture to say it's grown, because if it grows and it's getting bigger, we're going to say the next picture we assume it's going to be bigger. Or a patient develops new symptoms. And sometimes that's disheartening to the patient, because we'll say, let us know if you have any symptoms. And that could be very scary. Well, last week I woke up on the wrong side of the bed, my neck hurt. Is that from this tumor? And it can cause a lot of angst. And so we sit there and I try to reassure them saying, well, let's watch this. You always have me to help hold your hand literally and figuratively through the process. And then the easiest way I sit there is say, well, do you want to have this procedure to have that out? That involves this, this, this. And sometimes patients say, now that you told me what that involves, I have an understanding of what my endpoint is. In other words, if it's a grade of rice not bothering me, but I have a surgery that might take some time to do, and I have to recover from this, they might say, I'm willing to watch. On the other hand, if they're symptomatic, that option for surgery to help them get rid of that pain often is something people want to do quicker. So what I always tell patients is, these are our options. It's not that the patient has to figure out the options. We're going to help them. And the way I always describe it to patients is, it's like coming to a restaurant. My job is to define the menu items, but the patient still has a choice. If they get the salad, it's probably healthier, but they might be hungry at the end. If they get the steak, a little less healthy, but they'll be full. Where are we on this? This is one surgery that we can do that's smaller. This is one procedure we can do that's bigger. This is what it involves. And as a team, we make a decision. So I never want the patient to feel like they have to go to med school to learn it. On the other hand, if I don't explain to them, they can't make an informed decision. And that happens not just at the level of the surgeons. It happens at the level of the medical oncologist and the radiation oncologist. Sometimes patients will say to me, so Dr. Schuerba, I was told by the radiation oncologist that I might need radiation. What are your thoughts about that? I'll give my thoughts and say, but you should talk to radiation oncologists, because all they do is radiation, and they're going to have a bias, which is meaning that their experience, not a bias in the bad terms that we often say, that in the prejudice, a bias meaning, in my experience, this is what I would recommend for myself, my family member, and for you, and that's where I would suggest. So, and again, just to conclude on that comment, 3 things. What is it? Larry and I were talking about that together. What is it doing to the neurologic function? Do I have weakness or numbness? And third, what is it doing to my spinal column? And each one of those is a different solution, a different tactic. So we have to think about it, and then we make a plan.
So that was talking about nerves of the spinal cord and of the nervous tissue. The bigger issue that we have to deal with is the structural part, which is the bone. And again, with the bone, we can have a tumor that arises primarily in the bone, or we can have a tumor that spreads to the bone, which is much more common. And so, Larry, do you want to kick off talking about bony tumors?
Sure. So, we are focused a lot here on the diagnosis, and I'm delighted that that's where we're centering a lot of this conversation, because as I said earlier, this is where the treatment plan starts. People come to my office and they want to go right to the treatment plan. And I say always to them, first we got to figure out what it is. And once we know that, everything else will become clear. And so it's great that we're spending some time talking about this very, very important aspect of what physicians who take care of patients with spine tumors do. First, collect all the information. And so when we get to now tumors of the spinal column, these are tumors affecting the bone predominantly. They can also affect other structures around the spine, the cartilage, etc. They really fall into 2 categories, as you laid out, Tom. There are the metastatic tumors, and these are far more common. And these are tumors that have spread to the spine from some other organ. Common organs, common primary cancers that metastasize or spread to the bones of the spine are breast cancer, prostate cancer, lung cancer, kidney cancer, and many others. These are cancers that many people know somebody who has this problem, and many patients with those cancers will develop metastasis to the spine over the course of their life. In fact, the metastasis is one of the most common causes of disability, pain and disability in cancer patients. And so certainly patients with a cancer diagnosis, you talked about how rare it is to find cancer in the patient coming in with back pain.
In my practice, he's not in your...
No, that's what I was going to say. But one of the red flags is hearing these symptoms in a patient that already has a known cancer, particularly a cancer that can spread to the bones. And so that's one instance, it's a particular instance where we need to have a little bit of a light flashing in the corner of their eye. Maybe this patient needs to have imaging or work up sooner rather than later because we know there's already been that they've already had a cancer. So there are the metastatic tumors that have spread from a different cancer, from a different organ. And then there are the primary bone tumors. These are tumors that originate in the bone, originate in the spine. And as you may have already guessed, these are tumors that come from cells that are part of the structures of the spine. So they could be from the bone, osteosarcoma, giant cell tumors of the bone, from the cartilage, chondrosarcoma, a variety of different primary bone tumors. And one that's interesting is a tumor called chordoma. This is a tumor that arises from cells that were part of the development of the spine, and so they're a primary bone tumor that almost always occurs in the spine, also the skull base and the very bottom of the spine. And so these are primary bone. They are much more rare. And again, once we identify what tumor type it is, this is the gateway to our prescribing a treatment. So it's important to first recognize whether the tumor is metastatic or a primary bone tumor, but that's not good enough. Then we need to know within each of those two categories what tumor type it is, because each of these types of tumors, whether they be metastatic, whether they be primary, require a different treatment. Some are very sensitive to radiation. Some are very sensitive to chemotherapy. Some are best treated with surgery. Believe it or not, even the type of surgery may be determined by the tumor type that it is. Whether you take the tumor out in pieces or you take it out in one big piece may be dictated by the type of tumor it is. So we keep coming back to this issue, and I think it's very important for the audience to know that when you are diagnosed with a tumor of the spine, the first major thing that needs to be done is to learn what that tumor is, because that's really one of, not the most critical piece of information in determining the path of treatment. So again, just to reiterate, we're now talking about the structural part of the spine, the bones and the support structures. The most common tumor type that we see in that area are metastatic tumors, tumors that have spread from another organ, from a cancer in another organ. And then much more rare are the primary bone tumors. And these cause their problems by expansion and growth and ultimately put pressure on the nerves. That's one way that people find their way to a doctor. They're having pain or neurologic problems because the tumor has grown and is now putting pressure on the nerve. Not different than the nerve tumors, but where the pressure is coming from is from a tumor in the bone. And the other very important way that these tumors cause symptoms, and Dan alluded to this earlier, is by affecting the stability of the spine. And I do want to circle back to something that Dan said, because it's just so important, is once we have our diagnosis and we're figuring out what to do next, that what to do next is very often driven by three major things, two major things, and the second one is what is it? If we know that this is a tumor that is going to grow and progress, and even if it's not causing terrible problems now, it will down the road, that's a signal to us because we know what it is and we know its biological behavior to intervene in some way. Doesn't necessarily mean surgery, but with some form of treatment. For a tumor that may not require treatment because of its identity, the other two things that drive us to treat are symptoms, the big branch of symptoms. And the two main symptoms are neurologic compression that can cause pain, numbness, weakness, affect your neurologic function, and instability of the spine, which also typically presents with pain, but can also present with a change in the alignment of the spine, something we call a deformity. The spine is no longer straight. The patient can't stand straight. And so what it is, and then what are the degree of symptoms that it's causing, are often the drivers for us to proceed with some form of treatment.
So we've talked about all the different nerve tissues and now the bony, and we really have to get into the real details of what today in modern spinal surgery, what we do about these bony tumors, if they're compromising the stability of the spine, or if they have to be resected in bloc or entirely to try to treat the cancer. So Dan, you want to kick that off?
Yeah, and not unlike what I said before with three things that I think about. I have this very simple, usually 3 rules. It's nice and people remember it. It's just how my brain works. The 3 things spine surgeons do, in a nutshell, I think I think I should tell my wife, I think I do more than these 3 things. But 3 things I think I do regularly and can help patients is, 1, to Dr. Rhines' point, take out an offending agent to remove something that might be dangerous. Number 2 is to decompress. So just like we've described, someone's pushing on a nerve and causing pain, someone's pushing on a spinal cord and causing this decompress. And the third one is stabilize in some way. Stabilize because something's broken, or realign when we stabilize because there's been an alignment change, a deformity, or scoliosis. And so those are things we do. And so what happens is sometimes patients will say, I heard of a procedure on the news or on a website. It's called an ectomy of something or a fusion of something. And before we get to the big details of this, I always say, let's talk globally about what we need to accomplish. If the goal is to decompress, sometimes the surgery can be very small because all we're doing, sometimes I say to patients, it's like taking a rock out of your shoe. Sometimes it can actually be quite of a minor procedure. You maybe take the shoe off and get the rock out. Maybe there's a procedure that can be very small. If on the other hand, going to the way extreme, this is an alignment issue where we're taking a leaning tower of Pisa, if you will, and we're pulling it back up so the whole spine is crooked. That may require a big operation with many implants, so screws and rods and metal to pull that patient from one position because we have to pull their whole body and straighten it up. And in between there is some combination to decompressing, removing. And as I say to patients, sometimes we have to put screws and they say, what will make you have the decision? 1, we can plan beforehand. We know we're going to take certain things that are going to be very destabilizing or very loosening up of the spine. And other times I'll say to patients, we probably don't need to put screws in or to fuse, but maybe on the way out, if we've left any concern that spine is not stable, we're going to leave it at least in a state that we entered, which is a stable area. So in terms of, that's the main 3 things: decompress, stabilize, and align, and also remove the offending agent. Now, one thing that I want to add on about this multidisciplinary approach that we have is that surgery is no longer, at least in my mind, and Larry can opine on this, it's not always our decision either. So for example, if the radiation oncologists have an ability to shrink a tumor down or treat it, sometimes together, each of us can do less. So let me give an example. If it used, in the old days where we didn't have all these technologies like focused radiation or certain drugs, the surgeon would be stuck taking care of every aspect of it, remove every bit of tumor, stabilize everything, and make it durable for their entire life. But what if someone told me, Dr. Schuler, we can shrink that tumor down with a pill, and we're going to go first? Well, now the operation becomes a smaller operation where I say, this is why we went to the medicine first, because now the operation becomes a different operation, becomes much smaller. Or we're going to try to get 90% of the tumor out because it's pushing on the spinal cord. You say, why don't take out 100%? Because maybe that'll make the surgery 2 or 3 times as long. And then when we're done, the radiation oncologist take out the rest of it. So what I always say to patients, if there's a radiation to follow a surgery, often for metastatic lesion, is it's like the surgeon there's a mess on a tabletop. Someone spilled something. And my job is to clean up, let's say, spilled milk. I clean up the majority of spilled milk, and you don't see the milk anymore. But you know that the table's a little sticky, or there's something left. And so that is the radiation oncologist comes in and basically cleans that area, takes what I call the residue away. It's probably a bad analogy to say they spray it with Lysol or some other cleaning agent, but they're taking away microscopic disease. And so it has to be, I would say, choreographed or coordinated, because what you don't want is at the end of something to say, oh, I thought you were going to do the part first, and I should have made, going back in time. That should be all thought of originally in ideal situations. And that's why Larry, and I know we feel strongly about this, we've known each other for years, is that first opportunity to think and to really plan is the best. And so sometimes, and I'm sure Larry feels the same way, I see a patient, and just like Larry said, I'll say, let's take a deep breath, we have to do some more tests. And if I were in that patient's shoes and I can feel it, they're saying, can we please do something right away? And I say, what I don't want to do is I don't want to run fast in the wrong direction. We all want to get there quickly. We just don't want to go in the wrong direction quickly. So we sit there and say, if we think about this, get input from other colleagues, we find ourselves saying, maybe the procedure is small. Maybe the procedure is easier. Maybe we get this out faster if we do it in a coordinated step. So back to your original point, though, when it does become surgical and patients can name all the different procedures, it's really to decompress, to stabilize and realign, or to remove the offending agent so it's never in that person's body again.
So Larry, I don't want you to expand on that, but I also just want to kind of put this in scope for the patients. And it's kind of hard to do, but what's a duration of a short operation for a tumor versus a really long one? Just give me the spectrum.
Yeah, well, is it okay if I sort of...
Yeah, go ahead.
And expand first?
Right.
Because I think Dan sort of laid out what makes me maybe the most optimistic about treating patients with spine tumors, and I've been doing it for almost 25 years. I'm the most optimistic that I've ever been, and I think Dan hit on it. This is a team sport. Very often we find diseases where it's in one domain, but in oncology it is an absolute team sport. And I think the places that do it well, I know where Dan is, and at MD Anderson, we inherently recognize that many of the diseases we treat require the expertise of physicians in different disciplines. There are diseases that I treated when I first came to MD Anderson that went to the surgeon, and we took care of it. And that same disease now, 25 years later, may rarely come to the surgeon because of the advances that have been made in other disciplines. And when we talk about oncology, we're mainly talking about three disciplines: surgery, radiation, and then what I call medical oncology, which is the chemotherapy, the targeted therapies where they give you a medicine that's directed at an abnormality of your specific tumor type. Many people have now heard of immunotherapy, where they alter your immune system to go after the cancer. These were things even 20 years ago that we just didn't have or were very under-evolved. Part of the reason why we all need to work together is that as a surgeon, you cannot possibly keep track of the advances that are happening on the medical side. They are happening so rapidly. So we work together for two reasons. One, no one discipline can be a master of all the options that we currently have. And number two, we know that the patient care is better when we all work together and combine our motives. So Dan was giving examples of one person's role is to clean up the bulk of the milk, and the other comes in and mops up what's left. This is how we work together now. And when patients come into a center that treats patients with spine tumors, their case is typically reviewed by a surgeon and by a radiation oncologist and by a medical oncologist. And behind the scenes, we're having a conversation about what are our it's like poker, but it's an easy game of poker because everybody's cards are on the table. You say, what can I do about this? What can radiation oncology do? What can the medical oncologist? What are our options? And who's our best? And therefore, who goes first? And how do we coordinate this care? And so between the multidisciplinary view and the options that each discipline has, I think it's maybe the most exciting time to be taking care of tumor patients that we've ever had. So, a note of optimism. As somebody who takes care of these patients, I am extremely optimistic. When I see a patient and I know they're incredibly anxious, I call myself a realistic optimist. We present the facts and we present the data, but I think in the overwhelming majority of cases, there's a cause for real optimism, because we've never been at a point where we had more options available or where we were working together. And just again, to go back to what Dan said, there are literally operations that we planned that 20 years ago would be a huge 10-hour surgery, getting back to the magnitude of the surgeries, whereas now I know I don't have to take all of the tumor out because I've got a radiation oncologist who's going to come in there after me, and aside from the part of the tumor that was squeezing the cord, the part that's very hard for them to treat, if I take out that part, they can lick the rest. Now I've got a 2-hour operation instead of an 8-hour operation, followed by a single shot of radiation. So, think about that. 15 years ago, it's 8 hours of surgery. Now it's 2 hours of surgery and a zap of radiation. And how does that make its impact? Number one, it's a lot less for the patient to undergo in terms of treatment burden. But also, many of these patients need to get on with their chemotherapy. They need to heal from their surgery. A lot of things need to happen. If we can expedite that and make that easier, then it's a win-win. So getting back to your original question, I opined there. Dan had invited me to do that. But the length of the surgeries really range tremendously from what are you trying to achieve. Is it a simple decompression? Is it more than that? Is it enough to just take a little bit of the tumor off of the nerves and then send to radiation? Or am I dealing with a primary bone tumor where I have to take this tumor out all in one piece, remove multiple levels of the spine and rebuild everything? Those are two drastically different operations. So that can range from an hour to 24 hours, believe it or not. Depending on all the things we talked about. What are we treating? Because that'll determine what kind of surgery we need. What are we trying to fix? Is it pressure on the nerve, or is the spine completely falling apart? This will dictate the range of treatment options. But as I emphasize what Dan said, I think our surgeries are becoming more effective and safer. Because of our tight coordination with our oncologist, and maybe Dan will expound a little bit on this. I'll give you the lead in. The other thing is our surgical techniques, the armamentarium for how we do these surgeries, are allowing us to be less invasive. So I don't know, go ahead, your job. Go ahead. Maybe you let Dan talk about what are some of the things we've developed on the surgical side that let us get in and get out with the least damage.
Yeah, thank you for that, Larry. And the way that I've at least evolved on this side, I'd love to hear your thoughts, is there used to just be a ton of things we can do. And as I get older, maybe simpler in my thinking of this, is that things are going to the edges. And what I mean by that is in cases where my analogy is there's a rock in your shoe, and we just have to get that pebble out, and then you'll be right back on to doing your thing very efficiently. We're making those surgeries as small as possible. So the small surgery is now becoming a very small surgery. And I'll get into that about what do we actually do to make them smaller. And on the other hand, as you alluded to, saying there are some primary tumors that if we can get out in the beginning with a good margin of healthy tissues, so the tumor cells in theory are completely removed from the body, those surgeries sometimes are getting bigger. And let me talk about the two different tactics. So if it's something very small, maybe we can make a small incision. Maybe we can go using a certain type of small camera or a scope. People hear about laparoscope for their belly. That means a scope inside the belly, laparoscope. So some patients will say, can I have a laparoscope on my spine? It's not usually called the same thing because that's for the belly. So we'll say an endoscope or microscope. And so now we're sitting there going, if I just need to get a small tumor, like a meningioma, for example, that we talked about before, which is a benign tumor, but push on the spinal cord. Can I do this if the tumor is the size of a marble or a chickpea? Can I make an incision just larger than a chickpea? And maybe very small. And this is technology. This is the ability to see things, the ability to use instruments that can reach around corners, the ability to work in an area that's safe, but also leaves very little damaged tissues. Now let's flip to the other side, where maybe years ago we would say, this is too much of a heavy lift. This tumor is a scary, dangerous tumor that we don't know if we can get all of. I think we've now pushed the edges. A lot of us in our field have said, this is our one shot to get this out. So something like Larry said, like a chordoma. People say, hey, let's do a small operation on a chordoma. And I'm finding myself saying, in this case, we want it to be so comprehensive that we never come back again. And those are called en bloc, which is a term meaning in one piece. But not only do we want it in one piece, we want the piece to have no touching of tumor. So for example, you can imagine saying, I took this tumor out in one piece, but you left part of the tumor in the patient. So you got one piece, but maybe you only took half a tumor. The idea is a one piece with no tumor at the edges, and therefore we can, in essence, tell the patient we're shooting for a cure. And it still comes back. We keep circling back to this. I think it's very important. Those two are so far apart that we have to know before we go into the operator. The diagnosis of the plan has to be known, because what you don't want to do is tell a patient this is going to be very small and find yourself saying, as I use the movie Jaws, I wish we had a bigger boat. We should have had a bigger boat. We made this too small. On the other hand, why would I ever want a surgery that's bigger when it can be done with less invasive, with a smaller incision, with a couple sutures that close that incision? Why would I want an incision that puts me and lays me up in bed for a long time? So what I always say is we offer what is the appropriate procedure. If someone says, why is the procedure so big? Because the problem is one that requires a big surgery, one that might be 10 hours long. I don't ever want a surgery for 10 hours unless I need it. All right, so it has to be appropriate. If it can be done in 1 hour, please sign me up for that, or smaller, but it has to be appropriate. And so that basically the answer, but both thank you for setting me up to answer your question, is some patients will say, can I have that small procedure? And you might be able to say, for this situation, yes, it's actually appropriate. Nope, your neighbor had that procedure, but you need the big one. And that's exactly what in 2023, we think is the most appropriate thing. Now, maybe in the future, that big surgery, with the advent of technology and the advent of advocacy and donations and research that we're all part of this, maybe we'll discover new techniques that make those big ones smaller. Maybe in the future, all those big ones will become smaller procedures, or we won't need surgery at all. But until that time happens, we're always going to tailor. You know, Tom is taller than me. I know you can't tell while we're sitting here, but his jacket is a different size. If I wore his jacket and he wore mine, we would be not ideal. So the surgeon's job with the oncologist and medical and radiation oncologist is to tailor that. Patient doesn't know that. That's why, again, it's so important when you first come in to take a deep breath and plan and get everyone's cards on the table to say, what is the best chance? Now, there's not only that time, but also time is an issue. So for me, if I got treated for a tumor today, what is my plan? Not only today, but in 5 years from now. Are we checking on blood markers? Are we checking with MRI scans or PET scans to say, Dan, we're going to try to do the best thing for you today, but we're also going to manage this 5 years because we know at your age with your type of tumor, in 5 years, you may have a different issue. We want to now not only plan for today, and so that's another thing to the people out there listening, is this may unfortunately be something that you have to deal with for a long time, not because you have to have more surgeries or radiation, but just so we as providers can stay on top of that. So for example, I don't know much about knees, but if my knee's replaced, people say there's a certain lifetime of that knee, but maybe for the first several years, I don't have to see any doctor, but maybe as time goes on, I should come back. It's not dissimilar or it's very similar for cancer patients or tumor patients that we say, you need to have checks that are regular, and it can be in the form of a blood test or a picture, just to make sure we're managing you perfectly. So even if you have a perfect treatment and you're cured, we don't ever want to rest on our laurels and say, you're done, you're fixed. We need to make sure that we keep you as healthy as possible. And I think that's to the benefit of the patient and the family, to give them constant reassurance and to make sure if there's any issues, we stay on top of it and address it right away.
Excellent. Excellent. So we've talked about the great advance in the team innovation, where we have a true interdisciplinary team working to best treat the patients. We know that there's DNA analysis of tumor, getting us to have better drugs to treat tumors. One of the big advances in spine that has really been monumental is the development of better instrumentation if a fusion is needed or support is needed, and the development of navigation to allow us to do it much smaller incisions and much more safe for the patient. But Larry, you want to talk about the advances in instrumentation and the impact on your field?
Every discipline that we've discussed has had their advances over the last several decades, which have brought a positive impact on spine tumor patients. And the instrumentation is no different than the others. Our ability to restore function, maintain alignment, and eliminate pain in many of these patients, particularly the patients with tumors of the spinal column, is based on keeping that spine stable and steady and in good alignment going forward. And one of the key elements to doing that is having good instruments. The development of stronger screws, rod materials that have different characteristics, some more flexible, some stronger or stiffer. We've actually begun to get into a realm now where some of the implants are made of materials that are not metallic, made of plastics or even carbon fiber, that may have advantages in terms of their strength, but also in terms of their ability to be invisible on imaging studies, something particularly important for spine tumor patients, I might add, because for spine tumor patients, we're following those patients and looking to make sure the tumor does not come back. And so the better you can see on those follow-up images, Dan was alluding to the idea that we need to keep an eye on patients after we're done to make sure everything is still hunky-dory. One of the ways we do that is with imaging of the spine, and the metallic implants have an impact on that imaging. And if we can use alternative implants that have less of an impact, cages made of PEEK, plastic materials, particularly, maybe we can improve that. The other way that those implants are making a difference, and this gets back to the multidisciplinary approach, is if you are a radiation oncologist and you have to go in after a patient's had surgery and plan a very careful radiation where I want to give as much dose to the tumor as I can, but not give too much radiation to the spinal cord or other important structures. One of the things that the ability to do that is founded on is my ability to see the tumor and see the spinal cord and make sure I know which is which and make sure I don't confuse one with the other. And if the implants that are placed are making it easier as a radiation oncologist for me to distinguish one from the other, then I could treat the tumor with a high dose, give the spinal cord as little dose as possible, and do that in the safest manner. Another potential advantage of some of the implants that have less of an effect on the imaging is the imaging itself is becoming more advanced. We now have imaging sequences that are helping us look at the biological activity of the tumor. We may get to molecular imaging where we're looking for specific chemicals in the tumor, and the better we're able to see, the more accurate that imaging is going to be. Another comment about the implants and how important it is that they're strong, sturdy, and durable is one of the things in other spine disciplines that's very important when we stabilize the spine is getting a fusion, right? So we put the implants in to hold the spine, but then we put bone or bone graft in that ultimately heals into the patient's own bone that takes over that strength role. So the implants are there to keep the spine stable while the bone heals. Well, in oncology patients who get radiation, patients who get chemotherapy, that's a challenging situation sometimes for that bone fusion to take place. The radiation and the chemotherapy can affect the cells that are responsible for creating that fusion and allowing the bone that we placed to become one with the patient's spine. So in our population, where the fusion may be delayed or may never happen at all, having implants that are strong and durable becomes maybe even more important than in other spinal disciplines. So that's a few words about the actual implants. We can also have a whole discussion on the tools of spine surgery and that we're using now, the navigation, the minimally invasive for doing these operations through tubular retractors, and we can maybe talk a little bit about that as well. But that's, I think, some of the big advances on the implants. Strong and sturdy and durable, and looking now into some materials that may be more favorable for oncology patients where we need very clear imaging follow-up, where we know the patients are going to get radiated, and so we need to see all the structures very clearly. I think those are some of the latest.
Well, this has been a fantastic conversation, and I've learned a lot, and I hope you've all learned a lot too, and I'm excited. So what we're going to do is close with a few words of advice, and Dan, I'll give you the first swipe at it. What advice do you have for the people out there?
Yeah, so first off, thank you for this wonderful venue to really talk very clearly about what we think is important for patients and their families and other providers. And so just to kind of conclude and summarize, we have to know what we're treating in order to help the person. So the first time a patient comes in is to take a deep breath. And the good news is, as Larry and I have been doing this and others like us for many, many years, we've seen patients just like you come in before, and we had many, many options for that. So really, you're in the right place, and we're going to start a plan. Personally, I'm very impatient, and I can empathize with patients where I want to do something and get rid of and take care of it. So giving anyone a plan is really reassuring. And sometimes the plan is more planning. Sometimes the plan is more studies, because as I said before, we don't want to run in the wrong direction quickly. We want to move quickly in the right direction. So the first thing for patients and families to hear is, let's get a plan and let's get plugged into a team. And the team is not only stronger and smarter, but it protects from any lack of knowledge. So although I might only have 80% of the whole understanding, if Larry or a colleague is also there, we've got it covered. So that's another strength. The last thing I'll say is when people think about second opinions, this is a big discussion, a big concern. Do you need a second opinion? And the rules that I have for that to help people, because you can always get 50 opinions. And sometimes at some point that becomes maddening and scary patient. You see a doctor, then you call your family member, they tell you to see a friend, then you talk to your mechanic, they tell you to see a friend, and it can become overwhelming. So the issues that I think for patients out there who are thinking, I think I have a good plan, but after listening to this, maybe I get another opinion, are three different areas. And think about this, and then I'll conclude. One is the procedure is really, really big, or something that sounds very, very invasive and scary, like a heart transplant versus taking an aspirin. If someone tells me I have a heart transplant, I'm going to get another opinion. If someone tells me you can take an aspirin, I'm probably good. So that's one thing, is the scale, the size of what someone recommended to you. The second issue is how rare it is. So if someone says, I've never seen this before, but we can try to figure it out together, you might want to see someone who's maybe seen more of these. So an experience matters. We all know that. So sometimes when things are very rare, you say, I might just want another opinion because someone might have seen this a little bit more and maybe has a little bit more insight or judgment or experience. And the third thing, which is more obvious, is if you just don't have a good feel. You say, I don't like, that's too far away from my family, or I just didn't jive with the communication, and I don't feel good chemistry with that provider, and I'm just looking for someone who maybe matches my personality a little bit more. And those are really the three things. Now, if all those are covered by one or two opinions, then getting 5 or 6 opinions to hear the same story can be quite detrimental to the patient, because it's a delay of a treatment plan. So understand that you always have the option to see extra people. You're going to be taken care of. And as Larry said, we have so much hope, and there's so many options. It's usually not that there's no options, it's what option does the patient want to do? So our job is to educate and give you all the best options, not only for today, but for the rest of your life, in dealing with this medical issue that just popped up.
Yeah, I think two things I'd like to close with. First of all, also appreciate the opportunity to share some of our experience with the patients who are out there and their caregivers. I think getting all the information up front prior to running down a treatment path is critical for almost any disease, but particularly critical for spine oncology, because you're going down the wrong path and then trying to recover can make things a lot more difficult. So be patient at the beginning while your physicians collect the critical information, the diagnosis, do all the imaging, because I think that really will increase the chances that the proper treatment is done the first time. And then again, what I said before, I'm optimistic, and I think we have reason for hope. Our medical oncologists have more tools at their disposal than ever before: chemotherapies, targeted therapies, immunotherapies. Our radiation oncologists have technologies now where they can give an extremely high dose to the tumor while avoiding the spinal cord, giving us rates of tumor control that we had never seen before. And as surgeons, we are able to do the things that are necessary through increasingly smaller and safer surgeries, getting patients back to their other treatments more quickly, and we work together. So more options, better options, and the team, I think, is, in my experience, dramatically improving the care we're able to provide for patients with spine tumors. I'm very excited about that.
Well, this has been fantastic. I know that our role at the foundation is to provide knowledge which can give you hope. And I think we've done a lot of that today. The important thing to know is that there are options for people that have cancer. Cancer is a scary word, a scary diagnosis. But if you do get diagnosed with that of the spine, understand that there's not one person that can treat all that. It's a team approach, and that's what we've learned today, is that we have to rely on a team. Technology's evolved. The biology of managing tumors has evolved. And with that, there's great hope. So I'd like to thank everybody for sharing their thoughts, and hopefully you found this educational. Rita?
I'd like to thank the healthcare heroes who put the best of science to practice every day for their patients. And I just want to thank you for what you do and for sharing your knowledge with the National Spine Health Foundation. So thank you, Dr. Rhines, Dr. Schuler, Dr. Schuler. Thank you.